Welcome to the Queens of Moxie, a podcast all about empowering women to reclaim their moxie, their power. I'm Mary Kay Campbell, and I'm the host of this program. Each week, we'll talk with amazing women who have reclaimed their moxie, overcome challenges, and are living their best life. So let's get started. We're here today with Dr. Pinkerton, who is I'm going to read this because there's so much information, and she is such an outstanding leader in this industry. So she went to her undergrad here at University of Virginia. She went to Medical College of Virginia, which is now VCU, for her med school, and then she did her residency here at UVA. And to give you just a little bit of what she has and what she brings to the table, she is a professor of obstetrics and gynecology, as well as the division director of Midlife Health here at UVA at the health system. She is the executive director emeritus for the North American Menopause Society, NAMS. Is that how you say it, NAMS?
NAMS.
Okay, perfect.
Great organization.
Super. She is also a certified menopause practitioner with NAMS. She's a longtime fellow of the American College of Obstetricians and Gynecologists. She's the past president of the South Atlantic Association of Obstetrics and Gynecology. She served as the president of NAMS from 2008 to 2009, and she served on many national and international committees. Those are just a couple of the things. I'm not going to read them all because there's so many, but some of the top honors that she's received are pretty outstanding, like the best doctor and top doctors in America since 2010. So that is a national recognition that you have had for 12 years now. And this year she got the SAAOG Lifetime Achievement Award, and she is in the top 1% of America's most honored professionals since 2020. So for the last year, she's been recognized as one of the top 1% in our country. Pretty remarkable. She has peer-reviewed 140 publications, 30 invited papers, 11 invited chapters, served as a principal investigator for more than 30 clinical trials. She has 3 children, one whom is deceased, Jeremy, in 2010. Katie, who lives here in the Charlottesville area and actually has a 9-week-old baby, and she also has her master's degree in graphic design. And Liz, her daughter, is following in her footsteps and is in her 3rd year of residency in OBGYN at VCU. So if you have heard all of that and aren't overly impressed, then you're crazy, because Dr. Pinkerton, you are just amazing. And I know this as one of your patients, but also, you know, this is really remarkable.
So I'm going to say that being a grandparent is one of the best things you can do. And Elizabeth, my daughter, would say she's not following in my footsteps, she's in her own footsteps.
Good for her. Good for her. Tell me, you know, you've been in this field for a while. Mm-hmm. What made you decide to focus specifically on midlife and menopause?
You know, it's interesting because I love to deliver babies. I love to do surgery. I started clinical trials, and then my chair said, let's start a menopause clinic. I'm like, sure, I'll add that on. I'll do the teen health center, I'll do the menopause clinic, I'll deliver babies, I'll do surgery. And then one day I said, I can't do all of those things. And I really liked menopausal women, and it was an interesting field. It has never bored me. It's continuing to change. And women's health, which is the broader field, is just such a challenge to help women take care of themselves, to figure out what to do at menopause, and then how do we stay healthy as we age. And many women, you know, they stop seeing their gynecologist after they deliver babies, and no one ever focuses on them and their health and their heart and their bones and their sexuality, and that's what we do.
Right. Well, and we know as women, we tend to pour into everybody else. We tend to focus on all the other people in our lives and the other things going on. And at least for me, you know, my wake-up call, unfortunately, was a traumatic car accident. But I think a lot of women find themselves at this point in their lives stopping and saying, wait a minute, what about me?
Well, that's what you want to happen. What's really happening is that women are just so busy. They've got their family, teenagers maybe. They've got work either at home or in the workplace, maybe moving into positions of responsibility where they've got, much bigger jobs. They've got relationships where hopefully they're committed trying to keep those going. They've got responsibilities in the community, at church, and they kind of forget about themselves. And they stop exercising, they're stressed, they're eating more, they're sleeping less, and then perimenopause comes with fluctuating hormones, and all of a sudden it becomes danger, 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 I need to pay attention to me.
Right. So it's unfortunately a time when their body literally says to them, you're going to stop and take care of me, because if you don't, there's going to be something pretty traumatic that happens.
Well, and I think that, we always knew that menopause, which is a year without periods, was a defining moment for women. And we thought about hot flashes and treatment for menopause and should you take hormones or not. But it turns out that perimenopause is actually the hardest time for women because it kind of sneaks up on you. Your kids are a little bit older, you're doing more things, you're juggling more balls, and all of a sudden you skip a period, or you have a heavy period, or you hemorrhage through your clothes, or you start snapping at your boss, or you have killer headaches, and you go, what's going on? Or you gain weight, or you can't sleep, or your sex drive goes out the window, and you're like, I don't know what's going on. I must have some dread disease. And what you really have is that your ovaries are now beginning to fluctuate, and at a time when you're under the greatest stress that women are under, you're not getting your support that you used to have.
Right. So when does perimenopause typically start, and how long does it last?
So if we put menopause average age 51, but the range is 45 to 55, and we think about perimenopause, which is the time leading up, that transition time, on average it lasts about 4 years, so you would think that it's going to be starting around 47, 46, but for some women it will start in the late 30s, and for some women it won't start till they're 53 or 54. So it's that wide range. So if you come in you're 30 and you tell me I'm having irregular periods, or I've got really bad PMS, or worse, that it's affecting my work or my home, the doctors are just like, you're fine, you're not anywhere near menopause, but you may be going to be that person who goes to menopause at 45, so by 40, 41, you may be well into your menopausal transition. And what's been interesting to me is to get calls from journalists who are all of a sudden starting to go through this process and going, oh, what's going on?
Right.
Help me, I'm not able to function the way I normally do. And I think we, in the United States, do a really poor job of supporting women in the workplace, particularly when you go through this. Think about, when you're pregnant, everybody can tell that you're pregnant. Everybody's like, oh, you're pregnant, when are you going to deliver? You're going to have this baby, and then you're going to get time off. And it used to be 6 weeks, and now I understand for some women it's longer than that. And then when you come back, and if you're breastfeeding, you get time to go into a room and pump if things are good. But when you're going through perimenopause, and your work is really high, and you may be in a leadership role, nobody wants to hear that you have a headache, or you need a doctor's appointment, or whoops, I'm flushing, I need to go cool off, or I need to go change my clothes because my period just started and I wasn't expecting it. So those are all things that are embarrassing, and women, back in the when I first started, nobody wanted to talk about hot flashes. It was a taboo subject. Well, now perimenopause is taboo because people feel like if you're going through perimenopause, you're aging. You might not be the best person for that job, or that somebody else might be better that's younger. So I think we as a society need to step up, and women need to say, you need to respect us during this time, recognize our stressors, and realize that we're at the best that we are. We are at our best, and we're even going to get better.
Right. And, that whole ageism is a very frustrating thing, because I can admit, when I was fresh out of college and new in my career, I thought I knew everything. I did. I can acknowledge it. I now have a 17 and 20-year-old, and so I can see a little bit of that reflected back. And what I failed to notice then and understand was that while I might have new and fresh ideas and I might understand the latest technology more, what I didn't have was that wealth of knowledge and experience, having seen things and done things that give me a different perspective. And quite frankly, now that I'm 50, I can, and that happened just a couple weeks ago.
Congratulations.
Thank you.
You're welcome.
But I can say that I have a different way of approaching things because of my age, because I recognize that pausing before responding, really getting different perspectives, and really trying to have that broader understanding of things makes a big difference in how you approach things. And when you discount someone because they're older, you're losing all of that institutional knowledge as well as just depth of knowledge.
Well, there's book knowledge.
Right.
And there's experience. And if you're really good, as you age, you put them together.
Right.
So the type of medicine that I practice is evidence-based.
Yes.
And I'm always learning. I'm always reviewing articles and finding out where's the field going, what's the new information, what did we now know that we didn't know before. I'll give you an example. We always think about depression as something, it's genetic, you either have it or you don't. Well, it turns out that there's hormonally related depression. Mm-hmm. So some women have it in puberty, or postpartum depression, or perimenopausal depression. So whenever you have hormonal changes, you're at higher risk to have this. So now we need to be thinking, ask a woman, did you have a postpartum depression? I need to know that when you're going through perimenopause, because depression or anxiety may be a big issue for you. Right. And with all that we've learned about trauma and trauma-informed care, right, it turns out that many of those childhood traumas carry with us when we age, and those we get the hormonal fluctuations and also those memories and things that were just sort of stuffed down start to come up, and we have to deal with those. Mm-hmm. But if you don't pay attention, if you don't learn where the field is going, you're not going to know that. So you can learn a book, you can have experience. When you put the two together, when you do what I call evidence-based medicine, that's really what's the best.
Absolutely. I can say from personal experience, you knew immediately about something that I had never told you about. And I have been to, I'm 50, I've been to many gynecologists and OBs over the course of my life, and it was immediate. And I remember thinking, oh my gosh, I wish I'd known that 30 years ago, 20 years ago. And that piece of knowledge has shaped other things that I'm doing as a woman, and I'm still going through physical therapy from my car accident, and so some of that is surfacing, mm-hmm, and it's allowing me to know what's going on and to deal with it appropriately. Yeah.
Which makes sense.
Yeah.
And because a lot of this doesn't come up until right, you're in this perimenopausal transition, people don't really know that they have things down there. And loss is a big part of it. People who lose parents or children, those are things that affect you as you move forward. And what's interesting about your ovary is it really does provide a lot of support. Hormones help women cope better. And one of the things we learned with postmenopausal hormone therapy is that it can sometimes help anxiety and mood, not as a treatment of itself, but as a support.
Sure. Well, so I had an IUD for years, and then when I was in my car accident, the force of the accident, we believe, caused it to, they thought, go through my uterine wall, and then it turns out that it was deeply embedded, but I had to have it surgically removed. What I didn't know was that having the IUD that I had, which had hormones, was preventing me from having menopause or premenopausal symptoms. And it came out, and I immediately got these ridiculous hot flashes, like literally grab my hair and drain it like I was wringing out a wet towel. And I thought, this is insane, because my mom had told me, oh, menopause is no big deal. When I had menopause, I didn't even realize it. I just woke up one day and realized I hadn't had a period in a while. So I had anticipated it being no big deal. Well, that was not the case for me. And so while I still get hot flashes, I am incredibly grateful to be on hormone replacement therapy. So can you give us a little bit of information about not just HRT, but treatments in general that people can take advantage of to help manage these symptoms?
So I think we should split it into perimenopause and then menopause. So perimenopause, which I actually think is much harder, because many women have what I think of as an Achilles heel as they go through perimenopause. For some people it's heavy bleeding, mm-hmm, headaches, depression, anxiety, worsening premenstrual syndrome, or the caveat of that when it becomes PMDD or premenstrual dysphoric syndrome, where you actually are affected at work or at home. And then we also have any type of underlying health issue can worsen as you go through this time. And then we also have to worry about contraception, because the second highest unintended pregnancy rate is women in their 40s. Because you think, well, I'm done with my childbearing, not likely to get pregnant, and then kaboom, we find these pregnancies. So we always have to think about contraception until you're a year through menopause or have documented blood work showing menopause. So we have to think about all of these things. And so when women come in, we're really trying to say, number one, if we have to deal with bleeding, oral contraceptives are often our first choice because they do two things. They control the cycle, they back your regular bleeding. They provide contraception for people who have worsening cramps. They help with that. And for some people, they help with mood. So that's one choice. But not everybody can take an oral contraceptive. You know, if you've got heart disease or high blood pressure or liver issues or any kind of estrogen-sensitive cancer, migraine headaches with aura, there's a lot of reasons you can't take them. So then what do we do? Well, we've got progestin-only pills, or we have what you probably had, which was a progesterone Iud, which is a local source of progesterone in that intrauterine device, but it also gives some systemic benefits. And then there's some brand new medicine called Listeta, which you can just take right around the time of your period and slows the bleeding down. So we have lots of options for women if they don't have specific medical things like cysts or fibroids or endometriosis. That's another whole can of worms. For mood, for PMS, you know, lots of times you can do lifestyle. So what happens to many women in their 40s is they don't exercise. You know, they're gaining weight, they're not taking care of themselves, they're stressed. So, you know, it's like, okay, let's put yourself first again. Let's find an exercise program that you can do, maybe in the morning because you're so tired at night. Let's cut back on those carbs and the sugars. Let's get, you know, healthier eating going. And then let's look at your stress level and what are you taking on and what can you give away. So a lifestyle is really looking and saying, if you are in good shape going into menopause, it's going to be easier to make that transition. And what happens is that it sneaks up on women because they're just exhausted from hormonal things and everything else. So lifestyle, and then we have over-the-counter things that may or may not work. You know, evening primrose oil, vitamin E. Some of those things can work. For hot flushes, you can try black cohosh or some of the soy products. And all of those things are okay if they're mild symptoms. But whenever you have big symptoms, we need help. So what do we do for mood? So if you're perimenopausal with big mood issues, we look at it and say, do we think this is hormonal or depression or anxiety? If it's a major depression, anxiety, we need some help. We need a therapist, we need a psychiatrist to help us with mood medicines. But if it's just hormonal, we may be able to handle it with, you know, either birth control pills or supplemental estrogen. And then we can add mood medicines in if we need them. And then, so that's one. Sleep is another big issue. You know, they've shown that to prevent Alzheimer's, you want 7 hours of sleep a night. So you've got a working woman who's really working hard, who's cutting into that sleeping time to have maybe her own time, or trying to get her work done, and so she shorts that, and then that causes her to gain weight, to be more tired and more irritable, and it's just a negative downflow. The good news is that we've learned a lot about sleep, and we have, you know, sleep apps that are out there, and we have white noise, and, you know, there are melatonin, as long as you get the USP brand, and then there's sleep aids for people who need them. But sleep is really important. The weight gain is just such a big issue, and I wish I had magic for women. I wish I could say, I know the answer, this is what works for every woman. But in general, because it's been a gradual gain, we talk about a gradual loss. And if you're exercising and sleeping better and your stress level is better, then you can focus on a healthier diet. And you won't have to have those carbs or that 2 glasses of wine at night to unwind. To unwind at night. And I read an interesting article that just said that during the pandemic, as other times, that women were drinking more wine.
Yes, I've seen that.
So, you know, 1 glass of wine, probably okay. 2 glasses of wine actually increases your risk of breast cancer, as well as it increases the chance that you're going to want to snack more, and you sleep less well.
Right.
You fall asleep faster, but you don't stay.
Your sleep isn't as good quality.
It's not good quality, and you may wake up with sweats or hot flushes in the middle of the night.
Mm-hmm.
So limiting alcohol is one of the things that women can do. Oh, what am I going to do? I need my, I need my
I hope it's not I need it.
Well, for some people it's an I need, and some people it's just that they want to have time at the end of the day for themselves.
Right.
But you can do sparkling water, you can read a book, you can do, herbal teas, you can take a walk, you can listen to a podcast. I mean, there's a lot of things that you can do once you think about, how to get out of that route. So we've got hormonal contraceptives and all of those issues. We've got some of the lifestyle issues. And then it's just really from that specific issues. Now, as you approach menopause, what happens? In the late transition, you start to skip periods. Most women. Some people go like clockwork and they stop. Not very many people. Most people will skip a month or go 6 weeks. And then they'll have a few regular periods, then they'll maybe skip 3 months. When you're getting to where you're skipping 3 months, you're in that late transition time, menopause is coming. And that's when some women will start having hot flashes and sweats, and we can intervene with hormone therapy, or we can wait till you're menopausal. So hormones got a really, really bad rap.
I know, I was very, very hesitant, and it was only because I was at a chamber event and people wanted to hug me, and I literally had water running down my face and on my nose. I mean, I was disgusted. I'm like, you do not want to hug me.
And I don't want to hug you.
And I do not. And I thought, and it really was, because my primary care doctor had suggested it, and I'd had the prescription for months, and I was not going to do it.
And why were you afraid? What had you heard?
Well, I had heard that it can increase your risk for breast cancer, and it can increase your risk for strokes and heart disease, and that it's synthetic, and that it's made from horses, and that, like, I think someone told me it's horse's urine, and I mean, like, all of this stuff. And so I thought, I don't want to put another chemical in my body.
And in one sense, everything is sort of true.
Right.
And so if you pick up, when you picked up your hormones, if you opened the prescribing information, there's a boxed warning that says that it causes breast cancer, heart disease, stroke, blood clots, and probable dementia. Why would anybody take it?
Right.
So then you have to say, well, let's go to the evidence. So in 2002, there was this first results from a very large clinical trial called the Women's Health Initiative trial, and they had half of the women were on a specific one type of estrogen, one dose, oral estrogen that came from pregnant horses, Premarin, with a synthetic progestin called medroxyprogesterone acetate, which is a potent progestin. And instead of being women at menopause, when we normally give hormones, these women started at average age 63. And so it's not the population of people that we're actually treating. And they were looking at it to prevent heart disease. Well, what they found out was that particular age group of women, that particular product, it actually slightly increased the risk for heart disease and breast cancer. And then in the older women, there was a slight increased risk of stroke. And if you were over 65 and already had brain changes, it actually did make probable dementia worse. What's probable dementia? It doesn't mean you're probably going to get dementia. It means they can't diagnose dementia, but you may have you may have the signs that they think it is. So that's why it says, and then the breast cancer piece was that at 5 years, there were a few more cases in the Prempra was the product that was used compared to placebo. So we had breast cancer, heart disease, stroke, blood clots because it's oral and goes through your liver, and probable dementia. So then, fast forward to the next study when they looked at estrogen alone, same estrogen, Premarin comes from pregnant horses, but it actually has some anti-estrogen effects on the breast. They actually found fewer breast cancer cases. But because it's oral and it was an older population, again, they saw, that it was not preventing heart disease or stroke. In fact, a little bit the opposite. And they said, oh, we need to stop this trial too. So all the trials stopped. Everybody went off their hormones. 25% of people went back on, and because they were miserable, and then we had to wait. So in 2007, they said, well, what about that group that's 50 to 60? You know, the group that actually needs it.
Right.
You know, what about them? Well, it turns out that they didn't see any increase in breast cancer. They actually saw fewer heart events, and that they didn't see any changes in brain function. So, and the risk of the blood clots is within the first year of oral therapy, probably for people who are at risk. So we will be able to say, wow, let's look at this. And if you were estrogen only, you actually had fewer breast cancer cases. And then we started to look at oral versus patch, or what's called transdermal, which is through the skin.
Right.
Turns out that that causes fewer blood clots and stroke. And then we started to look at different progestins and said, wow, there's a natural micronized progesterone that's bioidentical that doesn't have the same risk. And then there's differences in different types of estrogen. So all of a sudden, we're saying, wow, if you're 50 to 60, it's safe if you're healthy. And look at all these options we have, and how we can tailor to one woman the best choice for you to take.
Right, right. I know for me it's been just an amazing option.
So be specific, what has it helped?
Well, my biggest frustration was the hot flashes, and while I still get them, they are not debilitating. I'm not dripping. Now if I go and exercise, I'm still dripping.
Well, a 20-year-old might be dripping too.
You know, way more than I did when I was 20, but it's because I've been exercising, and it's raised my internal body temperature, you know, in general. But now I can go to outdoor events and not worry that I'm gonna have completely wet hair and water pouring off of me. I mean, and when I say that, I really do mean it was like little rivers of water. It was so awful, and so it has been life-changing. You know, even in the room we're sitting in right now, it's pretty warm in here, and I remember thinking they put a menopausal woman who gets hot flashes in here, you know. But I'm fine, you know. Am I warm? Yeah, but I'm not overheated, and so that was my biggest difficulty, and the HRT has made a huge difference, and it is life-changing because I can go and do things without the concern that I'm gonna just feel disgusting and you know,
so
look that way.
We would call that quality of life. But I want to explain one thing. When you're menopausal, so before menopause, you have this temperature zone that's pretty wide, and you get hot, like if you have the flu, or chills if you know, if you're having the opposite when you have the flu, you remember being chills and hot. But with menopause, it narrows in symptomatic women, so you get hotter or colder compared to other people around you. So there are things that can widen that, and the one that works the best is hormone therapy. Estrogen by itself, and we have to give a progestin or a progesterone if you have a uterus. But there's some other things for women who can't take hormones that also help. So some of the low-dose antidepressants, something called gabapentin, which is used for nerve pain, you'll know it as Neurontin. The antidepressants are like Lexapro, Effexor. Those are kind of the biggest ones, but almost all of them have some benefit on that. And then, like, you know, when they look at things like black cohosh or evening primrose oil or some of the phytoestrogens, they can't prove that they work better than placebo because, interestingly, placebo works 50% of the time. So we have to do clinical trials. So what's new and coming is really exciting. There is a whole new type of medicine called Neurochiminin, Neurokinin, Neurochiminin receptor antagonist. In the brain, they run right along that temperature zone, and it turns out that these medicines work as well as estrogen to reduce hot flashes, and very quickly within 2 weeks. So there's one of those products that's going to be coming to the FDA within this year, and then we're really excited because we just opened a clinical trial here. It's a multi-center trial across the country and Europe, looking on a second one. The first one is neurokinin receptor 1, and this one is a 1 and a 3, so we're looking at hot flushes, mood, and depression. And we're going to be studying women who have lots of hot flashes to see how well it works, and then we're going to compare it to placebo, and then we're going to follow them out. Some of them will be followed out for a year. So if you have women wanting women out there in the audience having lots of hot flushes who want to think about being in a clinical trial. You know, email us at midlife@virginia.edu or call us, because it's really exciting to have a clinical trial that is going to be something that is life-changing.
Yes.
And it's going to be really helpful for women who've had prior breast cancer.
Right.
Because that's a group, and some women just are not candidates for estrogen. If they've had blood clots before, or stroke, or this thing called fibromuscular dysplasia where their vessels narrow, or migraine headaches with aura, where we're afraid that they might have a risk of stroke. There are lots of reasons why people can't take estrogen, and we haven't had very good treatment options, and this new type of therapy looks really exciting.
So if they want to sign up for it, when does that window close so that we can make sure they know and reach out to you before then?
So the trial is open now.
Okay.
Meaning that people can let us know, and then if they're like they might be on a medicine, we have to wean them off,
of course,
to be in the trial, whether it's estrogen or something else. But if they just send that email, we'll probably be recruiting for the next 6 months, is my guess.
Great.
And there are also places across the country that are doing it.
Super.
And it's called the Bayer Oasis Trials.
Bayer Oasis Trials. And basically, if someone were to watch this later, it's June of 2022, so before the end of the year.
Yeah, before the end of the year, or check to see if they're still going on. And then there will probably be other clinical trials that are going on. So women who are suffering, who feel like there's no hope, there is hope. There is hope.
And I think that probably must be one of the really rewarding parts of doing your job, because you've seen so many changes throughout your career, and we have a long way to go, but at the same time, how nice to be a part of these clinical trials that are really helping women to address these and to have a better quality of life.
Well, and women were not in clinical trials until the last 30 years. And then, you know, that big women's health trial actually scared us so much that it set women's health back. But now I think we're moving forward again, and so we're really excited about that. And we haven't talked about libido and sexuality, but that's another big area where women need help, because many women, there's something called, it's a big word, genitourinary syndrome of menopause. Used to be known as vaginal atrophy. Nobody wants to have atrophy, so they changed the name.
So something really long and complicated.
So it involves your vagina, your bladder, and your urethra, and your vulva. And what happens is that over time women start to have painful sex, and they don't know why. Libido goes down, their desire goes down, and then it starts to hurt when they have sex, or burns, or it's uncomfortable. And many women don't talk about it, and unfortunately many providers don't ask about it. But there is help, and that's one of the areas where I think women need to know that wherever they are in the country, if that's something that's an issue for them, if they go on the NAMS website, which is menopause.org, there's a little section for women, and you can look up by zip code and find practitioners that are menopause specialists in your area. And they should be knowledgeable about how to help with painful sex and get people's relationships back where they want them to be.
That is such a valuable thing for women, and I think so many women are afraid to talk about it, and or they talk about it, but they talk about it with their girlfriends, and their girlfriends don't have the right answers either. So what are some of the treatments or some of the options for women who are having pain with intercourse?
So the first thing, we always start with the lubricants, and all lubricants and moisturizers are not created equal. So, you know, if you're having painful sex and it's just a little dryness, there are water-based lubricants, there are silicone-based lubricants, and so using a lubricant, using it regularly, making it a part of the lovemaking process can really help. The next step are moisturizers, and I tell people to think of your vagina kind of like you're watering a plant. And so with a moisturizer, you need to do it twice a week, at least. And these come as gels, which are really messy, but they work. And you can also buy online some suppositories now, and those are used twice a week, and they're made of something called hyaluronic acid. And it just turns out that it really does work to make the vagina less painful. So those are not hormones, things that anybody can buy over the counter and use. if those are not enough, then we start thinking about what products do we have that are tested and approved. And those are usually vaginal estrogen products.
Mm-hmm.
There's creams, tablets, suppositories, and a ring that you change 4 times a year.
Mm-hmm.
There's a product that it goes by the name of Progesterone, and it is intravaginal DHEA. It's a pro-hormone that actually turns into estrogen and testosterone in the vagina. So sometimes that's the right answer for women. Interestingly, there's an oral pill that is a designer estrogen that's been approved for vaginal dryness and pain with intercourse.
Mm-hmm.
So for people who have rheumatoid arthritis and they can't put anything in their vagina, that's an option. And then, the real problem are women who've had breast cancer or an estrogen-sensitive cancer. They're so worried about, can I do this, can I not? And what I would say is, number one, if you're thinking that you need help, you need a good gynecologist, and you need your oncologist to be on track.
Right.
You need to say, I'm having painful sex. If they want to recommend vaginal estrogen, do you think it's going to be safe? So I can take women who haven't had sex for 6 years, and it may take us 3 or 6 months, but we can get that vagina back. If people want to. You don't have to have sex if you don't want to, but if you want to, don't give it up.
Well, and I think it's so important for people to understand it doesn't have to be painful.
Right.
And I think also, there's at least in my generation, it was this, the girls don't have sex, and there was this whole mentality about, even being a sexual person felt like bad, and I think it's really important for women to know that you have needs, you have desires, you have every right to be satisfied and to enjoy sex.
Yeah, they don't know that, or they don't believe it. Mm-hmm. And a lot of breast cancer patients, as they go through their treatments, kind of stop having sex, and then it's hard to get it back.
Sure.
And then I think the other piece is that libido is one of those big issues, and I'm going to be quite honest, I don't have magic for libido for postmenopausal women. But having said that, there are treatments that are approved for premenopausal women. Mm-hmm. There's a product called Addie, which is a daily pill, and then there's an injection that you can take. None of those have been approved for postmenopausal women. Mm-hmm. A lot of women want to use testosterone, and we got very excited. There was a study that was using a daily testosterone gel, mm-hmm. and compared to placebo, and at 3 months, libido in the testosterone group was higher than in the placebo group. We were like, yay, we're finally going to get something for women that's FDA approved. And the FDA, with good reason, was worried about breast cancer and heart disease and said, we need a longer trial before we do this. So the trial went on, and at 6 months, they looked at the data, and there was no heart disease, and there was no breast cancer, and it didn't work any better than placebo. Mm-hmm. So it's, for women, when you think about desire, for men, often, it's an on-off switch. They see, they're interested, they're ready to go, until they develop their own set of issues.
We're not alone.
for women, it's like you're in an airplane, and you're the pilot, and you've got all these levers and rheostats, and everything affects it. If you're tired, if you're exhausted, if you don't feel loved, if you've given too much at the office, if you work too late, if you don't have sleep, if it wasn't fun, if it hurt the last time, if you can't remember the last time that you wanted to have sex, it's really hard to say that this is fun or enjoyable. And so part of it is recognizing the stress that women are under, mm-hmm. and kind of saying, you're going to have to put this back as something important. And yeah, you may have to be thoughtful about this. It may not be quite so spontaneous, right? But you can get that part of your relationship with your partner back if you want.
Yeah, and so it has to be an open communication. It has to be a trusting relationship. It has to be one where you're able to have that conversation to say, I am interested in this, and in order to have it be as enjoyable as possible,
This is what we need to do.
Right. Let's draw a bath.
Mm-hmm.
Let's have extended foreplay. Whatever it is that helps you to relax, helps you to feel connected, helps you to feel loved and cherished. All of those things go into a woman's ability to have an orgasm and even to just have that desire.
And and if it was successful, and whatever that definition is, so that you felt close at the end with your partner, you're going to be more willing to engage.
Right.
And then the other piece is that if what you're doing is saying, okay, Friday night at midnight, last thing of the night, okay, we're gonna do this. It's hard for it to be pleasurable and enjoyable. So it's where women have the ability to look out and say, how about if we meet upstairs at 9 o'clock?
If y'all couldn't see that, she was winking.
But just kind of making it more interesting and putting it back as something that's priority, because I want to come back to where we started. Perimenopause is just a really tough time for women because of all of their responsibilities, child caring, aging parents, work, community, church, all of those things, and lots of times we lose ourselves.
I could not agree with you more. So to round out the conversation today, is there anything that you think I wish everybody, meaning women who are in midlife, knew, or some big piece of advice that you would give to them to have them really start thinking about this for themselves?
If the best thing that your gynecologist does is give you a 5-minute exam and you're in and out of the office in 5 minutes, you are not getting your needs met, okay? So that's number one, that find somebody who understands what's going on and can help you work through the process. And then talk, let's not have it be a taboo subject.
Yes.
And I don't know how to fix it, at the organizational level, but at the persons and their relationships, talking with people, talking with your spouse. I have a great, visual I do with my patients who are perimenopausal and have children. I'm like, so your moods are going like this, and their moods are going like this, and when you get like this, both of you take a time out.
Yes.
Take responsibility that both of you are having hormonal events. Away, and then come back and talk about the issue. Communication helps. Recognizing that the week before your period you may not be at your best, that you may be more tired. Thinking about what you say yes to and what you say no to.
Yes.
Don't be afraid to utilize or try a birth control pill or hormone therapy or even a low-dose antidepressant. If somebody who's listened to you and talked to you and knows the evidence says, I think this might help you. And also, don't be afraid to see a counselor. A lot of us have a lot of things that are kind of stuffed inside.
Absolutely.
And I talked to somebody who said, I've got, a coach and a mentor and a therapist and, personal trainer. I'm like, I don't have time for any of that stuff. But, I have a spouse I can talk to and kids who will listen to me. And just recognize there is support when you go through this, and there is help, and that it gets easier. There's this concept that once you get through menopause, you're going to have zeal again. You're going to have that energy back.
Are you telling us that's not true?
It is true.
Oh, okay, good.
It is true that once you're through this difficult hormonal transition, things stabilize back out, and again you have more energy and you have wisdom and you have all that zeal that women that you want to have.
Yeah, that's fantastic. I cannot thank you enough for taking time. I know that you are incredibly busy, and we so appreciate you taking time to sit down and talk with us. And as I've said, I couldn't ask for someone who is more of an expert than you are. And I personally am just so unbelievably grateful to have you as my practitioner and to have this resource. And whether you're here in Charlottesville or somewhere else, I think your recommendation to find someone who specializes in menopause, specializes in this time in your life is really critical to addressing your needs, and also talking to someone who's going to listen to you and really pay attention to the nuances of what's happening with your body. So again, thank you so much for your time. You have been a delight as always, and I don't even know how I'm going to do the show notes because there's so much information, but it's been a pleasure. Thank you.
Well, and thank you, and to all of you out there, there's NAMS, menopause.org has lots of information. There are other people like me out there who really care about you and your health, and we want to help you navigate this difficult time.
Thanks for joining us on the Queens of Moxie podcast. Each week we come to you with amazing women who have overcome obstacles, who are living their best life and reclaiming their moxie. We hope to see you next week.